wanted to just share this with you because it's just fundamental to our whole course in integrated behavioral health. So, over the course of time, meaning the last 20 years or so, federally funded community health centers, not necessarily community mental health centers, but general community health centers that are supported by the federal government, um, have increasingly brought in behavioral health into their health centers because that's uh, often, if not always now, a requirement of that federal funding. Um, but here's the data point where things kind of are not necessarily clear as they might think on the surface. So, according to the data that the authors from the Journal of Substance Use Treatment found, that as of now 9 years ago, 75% of federally funded community health centers offered mental health services, um, but only 21% offered addiction services or substance use disorder services. And in fact, of those 21, they are, using the author's words, generally less integrated. Well, what does generally less integrated mean? Well, it means, according to the authors, that, again, using their words, significant portion of that 21%, their sole offering is a referral to another agency for substance use services. So if you don't count that as actually having addiction or substance use disorder services in your community health center, well, then you're talking, at least if you infer from what the author's talking about, you're talking to almost zero, right? So we talk about behavioral health integration, and we come to realize that we need, from a kind of policy and advocacy perspective, we need to ask, okay, well, we're not just going to do behavioral health integration, but what is your mental health integration, and what is your substance use services integration? Because the authors share with us here, the data suggest that those are two very different things, from the vast majority of them offering direct services to, when you think about services actually in-house, almost zero for substance use services or addiction services. So I thought this was a really nice, concise list of, and why I bulleted it out in the slide here. This is a really nice list from our authors of the Journal of Substance Abuse Treatment article about the challenges, or the not even the challenges, but the key factors to consider in behavioral health integration. And certainly those can end up being be barriers or challenges to integration. So, and I think you can read these points, and that they're pretty self-explanatory, but it's just a nice comprehensive list, ranging from funding. So just to give you an example of that, if I, on the occasion that I do have a direct conversation with a primary care physician, with a patient or client we share, meaning they come to me for behavioral health care, and they have the rest of their care or most of their care through primary. Um, if the if there's an opportunity to have that conversation with the individual's consent, of course, that's not billable for either one of us. So in most circumstances, even with the new billing codes we talked about, having two individual practitioners have a conversation about again, fair treatment plans, as for instance, those are generally not reimbursable. Um, and certainly, even today, there are it's a wide range of. Sorry, I didn't mean to highlight that one. I'm talking about this one here, of people in the community. Physician leaders, owners of medical leadership of large practices, as for instance. Much of primary care is much kind of like a reflection of retail. Mom and pop shops are fewer and farther between in primary care, and as is the case here in Frederick, most of primary care is part of a larger conglomerate, which is not necessarily in and of itself a bad thing. But if the leadership of that conglomerate is not open to integration, behavioral health integration, then it's not going to happen. And it'll not happen on a larger scale because um, you have lots of different offices, like as in the case in Frederick, Maryland, lots of different offices under the umbrella of Frederick Primary Care that roll up to a conglomerate. And again, just just to be clear, my experience with Frederick Primary Care has been overall pretty good. So it doesn't mean that because they're owned by a conglomerate that it won't integration will be resisted and not happen. But if there's not that support at the leadership level, that can have a much wider range effect as we see more kind of corporate consolidation of primary care. So in addition to having these nice kind of concise lists of key factors in behavioral health integration into primary care, they also did kind of a macro and a micro list. So think of last slide of that our outer contextual factors is kind of the more uh, macro aspects, and the intercontextual factors is kind of the more micro. And you see they're similar, um, but kind of again in a very kind of sensible way from an education standpoint, really highlighting the breaking down these factors into macro and micro. So two takeaways here from the author's research work and surveying and trying to create a process of support for integration, behavioral health integration into a primary care system, and then evaluating uh, how that went, for lack of a better term. So kind of a good news and bad news, that the ability uh, to create integrated care and to build, as they using their words, capacity for behavioral health support and behavioral health care within a private practice is quite doable. Um, but for uh, lots of different reasons, and reasons that many of them, in my opinion, things we already talk about in terms of stigma and not understanding, not having the proper education from a political standpoint. Um, uh, Addiction treatment, again, going back to their data point that they found in their lit review before their research, that also bore out in their own research that building capacity for addiction or substance use disorder treatment is quite a bit more challenging than mental health services.